I'll be taking the lecture on early RRT in kidney injury. We all know that acute kidney injury is basically a syndrome defined by loss of renal function over several hours to day, and it results from different noxious stimuli, sepsis, nephrotoxin, the circulatory shock, and the underlying pathogenesis is actually not well understood. And it is also diagnosed in context with other illnesses, and it is again, all of them patients are mostly in our ICU, and it can also cause a lot of problems. So what are the problems of acute kidney injury? Is basically you can have accumulation of waste products, harmful electrolytes, fluids, and as rightly said by sir, you can go into organ crosstalk, means other organs also will have the brunt of acute kidney injury. And there is increasing evidence that acute kidney injuries are seriously in a short term and a long term associated with morbidity and mortality outcome parameters, and again not to tell the costs which are there in any settings in India. So the definitions were changed, as we all know. The rifle criteria we started using, and then came the KIDIGO definitions and the staging of kidney injury. So with that, people started saying, just because I am saying acute kidney injury now, so shall I start doing renal replacement early? So that is the thought process of giving me this talk. So and that actually extrapolated from the previous studies that the mortality from acute kidney injury way back in 1970s was more than 50 to 80%, but still currently also the mortality has remained above 50%. So this led to the drive that whether we do renal replacement therapy early will make the outcome or not. So let's look at the evidence what we have. So the entire treatment of acute kidney injury is actually based on all these things which we see here: elimination of the toxic insults, hemodynamic support, respiratory support, the fluid management, electrolyte, medication dose adjustment, and last but not the least, renal replacement versus renal support. So what is this? Renal replacement means traditionally it has been said it is whenever you have a hyperkalemia, acidosis, severe pulmonedema, and any of the uremic complications, you start the dialysis. You need solute control, you need fluid removal, you need regulation of severe acid-base disturbance, you start the renal replacement. And the newer indication we started adding on of late were nutrition, fluid removal for congestive heart failure patients, cytokine manipulation in sepsis, cancer chemotherapy related tumor lysis syndromes, treatment of respiratory acidosis in ARDS, fluid management in multi-organ dysfunction. So there have been a lot of other associated indication in terms of partial renal support which were studied. But when few years back, when this was asked to nephrologists in US, what is your criteria to start acute kidney injury renal replacement? So most of them responded that it is because we see the patient more catabolic than is anabolic. So that is the time we started acute kidney injury. So what decides the outcome? So we are today seeing only timing, but apart from timing, let me be very clear, the modality used, the dose, and also anticoagulation will definitely affect the outcome of the patient when you are contemplating the renal replacement therapy. So what is this fuss about early, late? So early means when you need a solute control, electrolyte status more efficiently, more rapidly you can correct the hemostasis, and you can actually prevent the patients from going into complication related to AKI. So this means early. But early initiation also may lead to problem which are the side effects of the renal replacement itself. What are those? Hemodynamic instability, coagulation disorders, bloodstream infection, and even inflammatory or oxidating stress related to the membrane used in the dialysis. That patients are exposed to a risk of renal injury, and he may have an independent predictor of morbidity and mortality. So if you look at the studies, the first study which was published 15 years back, which was an RCT, actually had a negative result. That doing a patient's renal replacement therapy early did not show any survival benefit, and recovery of renal function also did not improve. So this was a study published 15 years back, but since then small studies were published, and that led to this paper in 2011 that they said numerous cohort, the gold pack is anyone who has these three things: refractory metabolic acidosis, hyperkalemia, refractory fluid overload. So these are the gold indications key to dialyze them urgently. And they also said that this have association with improved outcomes. And also the meta-analysis based on this data provided that it will benefit the patient. And then came in the last 5 years few studies which we will discuss now. The most talked about study is the AKIKI study, which was published in the NAGM. A large subset of patients actually did not say anything. And what they say is and mortality at 60 days was comparable, whether you do dialysis early or you do dialysis late. So this does not give you a mortality advantage, but this was followed by another trial which was published last year in JAMA, which was a contrasting outcome. The ELIAN study, which said that they revealed that early initiation of renal replacement therapy significantly reduced the 90-day mortality compared with delaying initiation of renal replacement therapy. So this showed a positive trend, and the NAGM article showed a negative trend. So which triggered a lot of meta-analysis, and all of them, 5 meta-analyses have been published this year, and they are the ones which is here, the PLOS One article, which said that we will do a meta-analysis on a different statistical parameter called TSA, trial sequence analysis. Means the older the trial, less powered, the newer the trial, more powered. And then one more was published this year in BMC Nephrology, a comparison of early versus late. And then one more was published in Annals of Intensive Care, where they again studied the same meta-analysis, same trials. And again, reading so many meta-analysis makes us confused. So the crux of all the meta-analysis, the 5 of them which have been published this year, is basically doing early renal replacement has no effect on renal function recovery, renal recovery time, RRT dependence, duration of RRT, and mechanical ventilation. It is an important fact actually. In mechanical ventilation time also did not change. But there was statistically lower rate of death was observed among surgical patients. All the post-op patients who developed acute kidney injury, especially the cardiac surgery patient who developed acute kidney injury, and those who selected subject who underwent a CRT. Again, all this is influence of this meta-analysis. So what are we doing? What are we dealing in this year? So is it like a blind man is touching the elephant and seeing it has come, or already when we see the elephant, it is already too late? So what is this? So let's see the basics of all the trial. All the trial which have been quoted in all this meta-analysis actually have begun from 2002 to 2016. The main problem of the trials is the timing. If you look at this, the last 2 trials which I just highlighted, the ELIAN trial started the renal replacement therapy at the beginning of stage 2, and their delayed group was at the end of stage 2 or the beginning of stage 3. The Godry trial, the NAGM trial, actually was one stage later. They started the renal replacement in the early group before the stage 3, and the late were allowed to wait for another 24 to 48 hours. And then came other trials which were prospective cohort. If you see, there was a huge difference in when they started. Some started as soon as the patient stopped passing urine, and some started when the patient was already anuric and had all the classic golden signs of renal replacement therapy initiation. So this was the problem in all this trial, major, where you start. And there were quite heterogeneous group, and most of them, as you can see, showed some difference of positivity. This yes and no is effect on the outcome, but majority also said no, there is no difference in the outcome. So why such difference in trials? Is because they had poor quality, there was a publication bias, there were heterogeneous medical versus surgical, and definitions were used differently, and the subtypes also were different. And different cutoff, as I told you, were taken as the beginning of RRT timing. So apart from that, the more controversial apart from timing is again the modality chose. CRRT versus intermittent versus SLED, the dose of RRT used, the dialysis membrane used, anticoagulation used, and the mode of the dialysis used. So all this makes situation in 2017 very complex for us as an intensive care clinician to decide what to do when the patient starts developing acute kidney injury. And what we have been doing since many years is actually not too bad. What do? We see the hemodynamic data, we give a fluid as Dr. Diveti sir pointed out, and last but not least, sometimes we put a Foley's and see if there is urine or not. Again, that has never been proven. Putting a Foley's in acute kidney injury improves the outcome or increases the urine output. That's not been proven. But we have been doing since many decades this. Knowing the fact that all the definitions of kidney injury are rotating among only 2 parameters. One is the creatinine, which is a very complex biochemical parameter, which we all know generates from liver, also generates from pancreas, also generates from kidney, and also is mobilized by the skeletal muscles. And the second thing which we have been using is the urine output. So if we club these 2 and actually see the pitfalls of urine output and creatinine in a critically ill patients, actually we are touching the elephant as what it. optimize the hemodynamics, optimize the volume status, avoid any exacerbation of the kidney injury, monitor, and if the patient worsens, then consider ART. Okay. Till we have any new data coming from the biggest trial which is happening, that is the START AKI, we should again see what Dr. Divetiya has pointed out in his lecture, the belief which have been published last week only in our intensive care medicine. The false beliefs are, if we see from the right panel, it has a lot of things for today's lecture. Effluent dose equals RRT dose, the answer is no. Effluent flow overestimates the RRT dose. Restoration of creatinine level after AKI implies full recovery, the answer is no, it is biased. To wean my anuric patients from RRT, I could try to force that. I can start Ditor, and now the urine will come, my patient is out of the kidney problem. That's the answer is no. As Sir rightly said, MAP is the principal hemodynamic target in patients with AKI. The answer is no. Mean and diastolic pulse pressure are the main driving force for this. And fluid challenge is always recommended in patients with oliguria. The answer is no. Fluid challenge only recommended when he is responsive. And IJV is the best access to the renal replacement therapy. Answer is no. Femoral also have similar performance in RRT structure. High blood flow rates in RRT cause hemodynamic instability. The answer is no. Net UF and rapid osmolality decrease may cause hemodynamic instability in patients. And the filters I am not touching, but with that I'll thank you for patient listening.